Welcome to Urogynecology for Beginners. I am Dr. Diksha Pandey.
I am Dr. Prandeep.
So Prandeep, what case you want to show today?
Ma'am, the recent one who came with bleeding PV and mass per vagina when she is
Okay, so when a 46 years old lady like this comes with a vaginal mass which becomes bigger when she strains, or which starts coming out when she strains, that was her history,
yes,
with spotting PV.
especially,
what is the first thing, especially in
urogynecology or PD?
So
the first diagnosis will be prolapse with vaginal ulcer.
And that's what everybody will think. So this lady, when we asked to bear down a bit, this is what we saw. And what is it? It is not prolapse. It is a case of fibroid polyp. So remember, whatever comes out through the vagina is not always prolapse. There can be hundreds of things, and one such diagnosis can be a fibroid polyp. Removal of this fibroid polyp, the one which is protruding into or out of the vagina, is an OPD procedure. This patient was given tramadol and atropine. The instrument you need are just 2 Valsalem. You grip the polyp nicely with the Valsalem and start. The steps are twist and traction, gently and steadily repeated multiple times. You will have to keep on adjusting the Valsalem one at a time and repeat twist and traction. Some people say you have to see how broad and thick the pedicle is. But if you trust me, there is no need for that. In no case of a fibroid polyp, in or out of the vagina, there is any need to clamp and ligate the pedicle. The twisting movement will lead to hemostasis by constriction of vessels in the pedicle.
And this patient has a fibroid almost covering entire cervix. You couldn't see the cervical opening itself. And how important is it to see the pedicle, or after surgery to clamp the pedicle, during surgery to clamp the pedicle?
So it's a very, very interesting question Pradeep has asked, and in past also incidences has happened with me where I was called in emergency that the pedicle is very broad and we are not able to clamp and ligate it. But let me make this very clear today that for fibroid polypectomy, you do not need to assess how broad or how thick the pedicle is. And there is no need of clamping it at all. So what is the procedure we do, Pradeep?
We will just hold with Valsalem and twist the fibroid.
And twist and traction. Twist and pull, twist and pull. And if you are patient enough,
until it gets released from the attachments, and automatically there won't be any bleeding or any.
Yes. And the mechanism behind why there is hemostasis is that when you are twisting, there is some kind of spasm which the vessels undergo, and because of that spasm, there is contraction of the myoepithelial cells of the blood vessels, and it helps to create vasoconstriction. So you can take it as my guarantee that in polyp you don't have to actually assess, clamp or ligate any pedicle. Just hold at the lower end and keep on gently having traction and twist and traction and twist. The polyp in 3 to 4 minutes will be in your hands. So you can try this, and I can take full guarantee that you will never fail. This fibroid looks like as if it is a degenerated fibroid, but all these fibroid polyps have some component of degeneration. So you will have to readjust your Valsalem again and again and keep on doing the same process with patients. And the process is twist and pull, twist and pull.
Ma'am, I have one more doubt in this. When we are pulling so much, continuously traction, is there any chance of inversion of uterus?
Prandeep, you are asking wonderful questions today, and I am sure that many of you would have had this doubt while doing or while you are thinking that you would do with this technique. So my answer to this is, remember what is uterine inversion? Uterine inversion means inside out uterus is coming down. So inversion can be only of two types, acute and chronic inversion. Acute inversion happens postpartum, when you are trying to pull the placenta from the uterus. But remember, that time uterus is big and flabby. So it has nothing that will contract and keep it in place. So when you are pulling the placenta out, the fundus also tries to invert out. Here, in this case, the situation is different. Uterus is small and constricted, and there is no atonicity or flabbiness. So the first reason is gone. Second reason, you might say that in chronic inversion also, there is an entity called chronic inversion. But in chronic inversion, when the fibroid starts pulling on the fundus of the uterus, on a normal uterus, it is a very, very gradual process in which happens over period of time, over months, and sometimes it takes even years. Here, when you are doing the procedure in one shot, if you are pulling it in 5 minutes, with a normally good contracted uterus, there is no chance. Supported uterus, there is no chance that the inversion can occur in those kind of cases. Apologies for the bad quality of video here. There was some issue with the lighting. But I hope you can still appreciate what we are trying to show you here. Readjusting the valcellum and giving traction and rotating it again. If it does not rotate well in one direction, you can change the direction. Readjust the valcellum and do the same thing. Traction and pull. Traction and pull. Do it gently. There is no hurry. It is not going to take a lot of time. And see, it is almost out. And yes, it is out. This is the final specimen. And this is the vagina with hardly any bleeding. You want to see the cervix? The cervix is speculous because the fibroid was coming out through it, but there is hardly any bleeding there. I hope at least a few of you would have learned a point or two today. Thank you.